everybody. I'm Jayatri, Chief Bioscientist at the Franklin Institute. Thanks again for joining me for another one of our conversations about the science behind the COVID-19 pandemic. Today, I wanted to dive into some data that has been coming out in the last week, showing how communities of color are experiencing disproportionate impacts from the disease. But before we get into that story, I want to talk about 3 quick updates on technologies and discoveries that are following up on some of the conversations that we've had before. The first one of these is about another vaccine that's made it to phase 1 clinical trials in the US. So the first vaccine that we talked about a couple of weeks ago was from a company called Moderna that's put out an RNA vaccine that takes a genetic material from the virus and delivers it into the body and just part of the vaccine's genetic material so that the human body can essentially make it a small part of the vaccine itself and then generate an immune response to that. The new vaccine that's gone into testing this past week is from a company called Inovio that's actually based here in the Philadelphia area. And it's been developed in partnership with researchers at another local research institute called the Wistar Institute. So we've got some Philly pride around this particular vaccine. And it uses a similar technology. This is a DNA vaccine, but it's also using genetic material from the virus delivered into human cells to generate that immune response. So it's another exciting step in a number of different parallel efforts to generate a vaccine against this coronavirus. Okay, so that's exciting update number 1. Number 2 is that we talked about how you can look at changes in the in the RNA sequence of the virus over time to get clues about where the virus has come from and where it might be going. Again, the way that scientists are doing this is by collecting samples of the virus from infected patients, sequencing the entire genome, and looking for these patterns of changes. So samples that share similar changes probably came from the same origin. And what was interesting that was discovered this past week was that by looking at samples of the virus that have been collected from patients in New York, it looks like the majority of the introductions into New York came from Europe, actually. So even while many of our studies have focused on the origins of the virus coming from China, this is a really good example in looking at how the virus spreads very quickly from one point to the next. And when we're thinking about strategies to contain the spread, we really need to be looking everywhere. Now, the third quick update to talk about is probably something that you've heard of because it hit the news big at the end of last week, because it's the first time that Apple and Google are actually working together. So another one of our conversations, we talked about how you can use the Bluetooth sensors in your phone to actually communicate between phones on a very low energy basis to keep track of other people that you may have come into contact with. Now, this is essentially a very technology-based, broad way to track who you might have come into contact with on an everyday basis. And so when you can then connect those contacts to a positive diagnosis for COVID-19, you can then automatically send signals to all of those phones to say, to tell their owners that, hey, you've been exposed to the virus. And a similar app has already been put into place in Singapore, but the fact that Apple and Google are now working together to essentially embed this technology into the operating systems of the vast majority of phones that are being used around the world is a big step up towards using technology for this contact tracing approach. Now, obviously, we talked about some of the concerns around privacy and security, and the 2 companies have put forth their draft specifications around what precautions they're taking, and whatever they develop will be an opt-in system. So if it's something that makes you feel uncomfortable, you don't have to participate. But at the same time, the way that contact tracing works best is when as many people as possible participate. So that's a third update that I think it'll be exciting to see how this technology evolves and the trade-offs that we're asked to make in order to participate. So those are some stories that we're going to continue to follow that are founded on some of the science that we've talked about before. Now, before I move on, do we have any questions around those?
Not yet.
Not yet. All right, keep sending them in. Okay, let's talk about this issue of why it seems that more minority communities are suffering worse impacts from this pandemic than we see in more white, affluent communities. Now, let's talk about some of the data that this is coming from. So last week, the CDC released a report that looked at hospitalized patients in 14 states across the U.S., looking at the month of March. And what they found was that even though the 18% of the patients who were included in the study, if you looked at the number of patients who were hospitalized, compared to that 18% who were African American, you saw 33% African American among those who were hospitalized. So that's a much higher level than you would expect just by the proportions of the participants in the study. Similarly, Chicago has recently released demographic data about patients who were affected by COVID in Chicago. And what that data shows is that 68% of people who have died and 52% of people who have gotten sick overall are African American, compared to just 30% of the population. So we're starting to see these trends, and there's other data out there too that shows similar trends, where African American and Latino communities seem to be getting hit harder with a deeper impact than we might expect just based on their percentage of the population. And so public health officials are really interested in understanding why, because we need to get a sense of those causes before we can take appropriate measures to try and help these communities. And so here in Philadelphia, as of last week, we just don't have high quality data about that breakdown. It's about a similar breakdown here in Philadelphia. About 36% of the cases that we have here are not categorized as to any kind of racial identity. And that's just because of some artifacts in the data collection process where some testing agencies are collecting that data, but others aren't. So we don't have a good picture of that in Philadelphia, but there's no reason to suspect that Philadelphia is going to be any different from any other city. Let's pause for a question.
Is there a truth to anyone taking CBD oil having higher risk of contracting the COVID-19?
So there's a question that's a little bit a different angle from what we're talking about here. So CBD is one of the components of the marijuana plant that is not the part that causes the addictive piece. It's a different compound that's in marijuana that is becoming more popular for different medicinal uses. I'm actually not familiar with any data that shows relationship between people who are using CBD and any particular predisposition to getting infected. So I'm going to have to take a pause on that question. We can come back to that once we have some more data on that. But in terms of looking at what factors do seem to be related to more severe impacts of the disease, scientists have been looking at what do we call comorbidities, or what are other diseases that people have that do make them more likely to contract COVID-19. And one question that's been talked about in this last week since this data came out is a higher proportion of some of those other diseases among the African American community in particular. Now, before I get into that story, I want to lay out two facts first of all. One is that race is not a biological construct. There's no genetic reason to believe that African Americans or Latinos have any difference in their biology that would make them more susceptible to COVID-19. The other piece is that some of the social factors that we'll be talking about are not specifically tied to race, but the legacy of racial discrimination in this country and how that's influenced some of the social systems that we have lead to the social construct of race directly influencing health. So I want to make those 2 points very clear before we talk about some of those relationships. Now, we do have another question, so we'll pause for that.
Is there any more clarity on how the virus is transmitted, aerosol or just high touch surfaces?
Right. So as we're talking about what these different factors that we're worrying about could be, there is another question about how the virus is being transmitted. There's more evidence that's suggestive of the virus being transmitted through the air, and that's why there's more support for people wearing masks in social conditions. But we still don't know for sure the extent to which the virus might be being transmitted through the air in very, very small particles versus being transmitted through closer contact in those respiratory droplets that come out of our mouths when we cough or breathe or talk or sneeze. Okay, so let's get back to this idea of why communities of color might be being impacted more severely. Now, what we know in Philadelphia, and I'm going to talk about Philadelphia data because we have a really good picture of health and social factors in Philadelphia based on work that was published in a really nice website last year through a partnership between the Philadelphia Department of Public Health and Drexel University's Urban Health Collaborative. And at the Franklin Institute, we were fortunate to work with these organizations to integrate some of these stories into our new giant heart exhibit that helps people understand how it's not just your genetics, it's not just your individual behavioral choices, but it's also the place where you live and where you work and where you play and where you grow up, where you were born. That geographical factor plays a really important role in your health. And scientists call these different factors social determinants of health. And so the very first thing that we encounter when we're looking at the COVID crisis is that starts even with testing, those inequities between different communities. So an analysis of some of the early public health data in Philadelphia showed that in the city, people in higher income neighborhoods are getting tested at 6 times the frequency of people who live in lower income neighborhoods. So that's going to be biasing some of our data right off the bat, as well as illustrating how even just access to testing differs based on where you live. Now, when we look at some of the data that existed prior to the COVID crisis, and you can explore this data for yourself at this website that is phillyhealthrankings.org. You can explore neighborhood by neighborhood to see how some of these factors differ in different parts of the city. Now, when we talk about some of those comorbidities or those diseases that make you more susceptible to COVID-19, those fall into the category that scientists called health outcomes. So what are the direct impacts on health that we can track from neighborhood to neighborhood? And just to give you some numbers here, looking at 3 of the comorbidities that increase your risk for COVID-19, let's look at diabetes. In Center City, the percentage of the population that has diabetes is 5.9%. Compare that to Nicetown, Tioga, where the prevalence of diabetes is 19.8, so over 3 times as much. We can look at heart disease. Again, another factor that makes you more susceptible to getting severe symptoms of COVID-19. The lowest neighborhood in Philadelphia is in University City, where it's 2.9% of people have heart disease. Compare that to Mill Creek Parkside, where that percentage shoots up to 8.5%. And then COPD, which is an airway disease that, again, increases your susceptibility. COPD frequency in Center City, in a relatively affluent neighborhood, is 3.3%, compared to, again, Mill Creek Parkside, where it goes all the way up to 10.4%. Now, remember we talked about the fact that there's nothing inherent about, and nothing biologically inherent about the prevalence of these diseases. But there are social factors that link this prevalence to communities where there are higher numbers of minority residents living. So if we just look at those two populations in Center City versus Mill Creek, Center City is over 80% white, Mill Creek is over 80% black. So this intersection of social factors has an undue influence on who it impacts. Okay, so we talked about these diseases, these direct health factors as being as leading to increased susceptibility. What are these social factors that are underlying those health outcomes? So let's talk about, for instance, diabetes and heart disease. We know that being able to maintain a healthy diet is important for controlling diabetes or lowering your risk of heart disease. So one factor that public health officials look at is how far you live from a supermarket. What's your access to being able to buy healthy food? Now, if we look at the range of neighborhoods in Philadelphia, in some neighborhoods, everybody lives closer than half a mile to a supermarket. But there are other neighborhoods where 65% of people live more than half a mile from a grocery store. So that then influences their ability to buy healthy foods, their ability to maintain that nutritious diet. Let's look at another one. What about access to medical care? So we can look at another factor that about when people had a recent routine checkup about their health. We know that preventative health care often helps people make a difference in long-term impact of diseases like diabetes or heart disease or COPD. Again, in the highest percentages in Philadelphia neighborhood, over 80% of people have had a routine medical checkup. Compare that to just 64% in other neighborhoods. Let's talk about some even bigger factors like unemployment. So in some neighborhoods in Philadelphia, unemployment is just around 3.5%, where in other neighborhoods, it's up at 27%. And when unemployment is related to your income, your ability to support your family, and especially your health insurance, we can see how those social inequities can lead to those different health outcomes. One last one to mention is air quality. So we know that even from some early studies that are being done in the US right now, you can look at air quality and the amount of particulate pollution that's in the air and correlate that to higher levels or higher impacts of COVID. So again, those are often likely to affect marginalized communities more so than wealthier communities. You can look at smoking rates as well. Again, coming back to Philadelphia data, there in some of the cleanest air neighborhoods, smoking rate is about 12.7% compared to almost 36% in other neighborhoods. And those neighborhoods where you see those higher rates of smoking are often where people are smoking to cope with the stress of everyday life. It's easier to get started smoking because studies have shown that in poorer neighborhoods, there tends to be more places that sell cigarettes. There's more advertising about cigarettes, and it's often harder to quit because there's less access to resources that can help you quit smoking. And so again, these sort of social factors over time have been influenced by policies informed by racial discrimination. Whether it's things like redlining, which was a practice that denied African Americans from getting access to mortgages that would allow them to buy houses in better neighborhoods, or whether there was discrimination in education that prevented people from getting higher education and then advancing in that way. So where does that get us right now? I think the positive thing is that it's raising people's awareness about these conditions. These conditions aren't new. But these stark differences in the data are drawing people's attention to how they're magnifying the effect of the COVID-19 pandemic on some communities over others. So we need more data to be able to identify more where these disparities are happening and what the causes are, so that we can tackle them most directly. But it's also a wake-up call for all of us to be mindful that we can't just focus on the biology of this disease. We need to think about the bigger picture when we're trying to figure out how to help the most people that we can. We need to think about, what are ways that we improve everybody's baseline health, so that when a pandemic like this comes along, everybody has a fairer shot at beating the disease. So before we wrap up for the day, do we have any other questions?
Nope.
All right. Thank you so much for joining me today. We'll be back next week. And in the meantime, stay safe, everybody.